Right, we'll get started and then others can join. This is recorded and will go on our Futures platform. We've got a smaller group this week. I was just saying earlier on with school holidays and things like that. We know we've had quite a few usual attendees who haven't been able to due to holidays, but this is recorded and will be on our Futures platform and will be shared to all of our mailing list as always. Next slide, please, Lola. So a little bit of housekeeping, which you all have already, so thank you. But if you can make sure your microphone is muted and your camera is off, just helps with any distractions during it. Please maintain, I'm sure you all will, but please make sure that if you are asking any questions, which may be patient specific, that we do maintain patient confidentiality at all times. If you need a break, please do. I do appreciate a lot of you will probably be attending during your lunch. So, I mean, you've got your cameras off anyway, but I hope you're all having your lunch as well. If you've got any questions, please pop them in the chat facility or raise your hand to ask anything. If you need any help, you can contact myself and the lovely Lola, who is on this call as well. And as I said, the event is recorded. And if you don't want to receive any further updates, please do let Lola know. This information is for North East North Cumbria alone. I appreciate some people may work across borders. And again, this will be recorded and will be on our Futures platform. So we have got the incredible Sharon Stoddart today. I always say I'm very lucky to have been able to hear her speak before. So Sharon has very kindly came and will be speaking about her own lived experience, which should be very thought-provoking, and also the incredible work that she has done within the Sunderland and South Tyneside Trust. So thank you so much, Sharon, for joining us today. And I will hand over to you.
Lovely, thank you very much, and thank you very much for having us and asking us to come and share the work that I've done and the work that we're doing in Sunderland and South Tyneside. I'm the sleep and respiratory clinical nurse lead for both sites. And I thought long and hard about the title of this presentation. So over the years, it's kind of evolved, and it started off as a very small project. And looking at it when I've been thinking about putting the slides together, it used to be learning disabilities in respiratory care, but reasonable adjustments don't just apply to patients who have a learning disability. They apply to all of our patient group on a patient by patient basis. So you don't have to have a red-chested or recognised learning disability to need a reasonable adjustment to be able to access safe and effective care. So I changed the title slightly. And it's all about thinking outside the box. So with this group of patients where we need to make adjustments, one size doesn't always fit all. And I think as clinicians and nurses, we love a protocol and an SOP and a flowchart, and we love that structure and that direction. However, sometimes that just doesn't work. And we want to engage the patients, and we want to let them have the best and best quality experience of the services that we offer. More than happy for anybody to such a small group to pop a hand up. I'm not very good at keeping an eye on the chat and the slides at the same time. So if anyone has any question, more than happy just to pop a hand up. That would be fantastic. So this is me. Been a respiratory nurse now for 27 years, worked in respiratory for over 30 years. And yeah, a lot of experience, a lot of changes, and still enjoyable. So as long as I can say that, I guess it'll carry on for a bit longer. So the background to my interest with the patients who have additional needs and learning disabilities was my lovely brother-in-law, John, who had Down syndrome. And John lived between ourselves, my husband and my family, and his mum. And there was a lot of diagnostic overshadowing with John. And if we hadn't been there to advocate for him, it's quite worrying as to what would have happened. So one example was that John started having seizures, which he'd never had before when he was at his day centre, and we got a lot of, well, that's normal for somebody with Down syndrome. Well, actually it's not, because he's never had them before, so why would he suddenly start having them? And there was other things throughout John's life. So it's always been a kind of, if you say, soft spot, and something that I know that work needed to be done. So then a few years ago, I met a lady on our corridor, actually, who was actually in tears looking for me. Someone from our ENT department had said, go find Sharon, she might be able to help you. her son, called Jonathan, had cerebral palsy, was very dependent on his mum and dad. He had could verbalise, went to his day centre, loved to go to the football matches, had a very active social life, and his general quality of life had deteriorated significantly over the space of 12 months. He did have like UTIs and chest infection, but his general behaviour had changed and his personality had changed. And Mum was so distressed about this, and she said he wasn't breathing properly during the night, so eventually got him referred into ENT. ENT then said there's nothing going on from that point of view. I think it's probably sleep apnea, and directed her, but didn't refer her on back to the GP, directed her on to me. This mum had been told that her son had delirium for 12 months due to chest infections and UTIs, and actually didn't. We diagnosed him with sleep apnea, and he's now back going to his day centre. His behaviour's back to normal. He's living his best life again. Absolutely taking the mickey out of me every time he comes in. And the whole thing about nasal adjustments is it's not what matters to us really, it's what matters to the person that we're actually dealing with. And if that's one thing that we can take away, because we get very wrapped up in ticking all the boxes and losing the patient in the process instead of looking at the person. And that's one thing that although sometimes we don't intentionally do it, it does happen. So reasonable adjustments were set out in the Equality Act, and that was in 2010. And this is just letting us know that anyone is entitled to the same care as anyone else. So people who have a disability, physical, sensory, learning, or long-term conditions such as dementia should not be discriminated against, and they should have access to equitable care the same as the rest of us. So from the learning from lives and deaths for people with learning disabilities and people with autism, it was identified some really interesting statistics. So people with a learning disability died 24 years sooner than the general population. 17% of avoidable deaths were linked to respiratory conditions. So obviously this is my bread and butter, and this is what I was looking at when I was looking at this group of patients and thinking, why are they repeatedly attending ED? Why are they repeatedly attending out of hours? GPs, 111, calling 999. It's a lot to do with understanding and the information that we were given to this group of patients and their compliance. 49% of deaths were avoidable compared to 22% in the general population. I mean, that's a significant number of avoidable deaths, that not just from respiratory, but from any death of this group of patients. And it was also identified, interestingly, that 50% of people with a learning disability who died lived in the most deprived areas in the UK. So there was work to be done, and we realised that on the back of this report. Then I went on to look at the national asthma deaths. And this was done some time ago, and it's probably due to be updated, to be honest, because it's quite an old study now, but still reading interesting statistics. And this identified and highlighted that 66% of medical records identified potentially preventable factors to the asthma death. 44% of those who died were identified as living with a learning disability, and 10% occurred within 28 days of the patient receiving hospital treatment, be that inpatient or outpatient. And a lot of these people did not call for medical assistance or help, hadn't involved themselves in services. It just makes you think, why? Like, is that around education? Is that around the patient taking responsibility? Is that lifestyle? So there was a lot to be learned from it, and 23% did not have a action management plan. So I went on to, got a bit of fire in my belly after getting involved in all of this, and looking at the national asthma deaths. And I wanted to see who was who was coming to A&E, because every morning I get an email, and I have done for years and years, from our data people to tell us who's been to ED who has asthma and COPD. And that was because the one thing I identified from the action plan, from the asthma deaths report, was that in our hospitals we were not addressing the people who were attending ED but actually getting turned around and treated and turned around at the door, but we were managing to address the patients that were inpatients because we were then picked up on them. So there was a lack of follow-up for these patients that went to ED and emergency services, but weren't actually physically admitted to hospital. So as I was going through the data that was coming through, these two things kind of were two things that I had in mind that I needed to do, but they suddenly became one, because I identified that there was a common theme. And the theme was there was a high number of these patients who repeatedly presented at ED who had a learning disability flag, or had a diagnosed learning disability. So what I did from there, I thought, okay, what we're going to do about it, we need to engage them in the service, we need to bring them back into, we need to make things easier for them to be able to access services, and we need to give them some understanding and empower them, give them a bit of empowerment, a bit of responsibility around their disease. So the first thing I did was, with this group of patients, have slightly longer appointment slots. And I know that doesn't always go down very well. I did have a bit of a fight on my hands initially. But that has made a significant difference to the engagement and the compliance and concordance of this group of patients. It was a small number of patients, but they were high service users. And that's when the trust suddenly pricked their ears up and said, okay, what we're going to do about it, maybe we can put something in place. They've usually got high levels of anxiety, so they struggle to identify whether they're breathless or they're anxious or they're just out of breath because they've actually done something. I've got one lady who gets very anxious about getting out of breath, and she thinks she's having an asthma attack, and every now and again I take her for a little march up the stairs and I'm more out of breath than she is. And then we're having a conversation about, well, it's all right to get out of breath, and trying to help her understand the difference between asthma making her out of breath and our actual physical, like our exercise tolerance making her out of breath. And also literacy levels. We were sending out appointments to these people who often have very low literacy levels. I don't have a carer who has good enough literacy levels to support them. Our trust went to text messages. So lots of people get text message appointments and they don't even have the equipment to be able to read it on there. So there was a lot of work to do and a lot of digging to do. So initially it was a 6-month project, and I identified 28 patients over some 6 months that were frequent attenders to our ED or out of hours services. So how the clinic works. So I have two reasonable adjustment clinics a week. One is specifically for respiratory conditions, that being anything, like literally anything at all. It started off as asthma, but then it just snowballed a little bit. And then I have one specifically for sleep apnea, because people who have a learning disability have a much higher risk of obstructive sleep apnea, and especially people who have Down syndrome or cerebral palsy, their risk is around about 60 to 70%, whereas in the normal population it's much, much less than that. So I've done a lot of work with our community learning disability nurses, and it's now part of the yearly health checks that they get screened for obstructive sleep apnea, which is absolutely brilliant. However, has caused us a bit of a tidal wave of referrals, but it's so worth it. And our hit rate is very good in getting these people diagnosed and treated. So the clinic's managed by me. And I bring people in for their first appointment, and to be fair, I don't really do very much. And I know that sounds like an absolute waste of time, and everybody prickles about it, but it's more like a fact-finding appointment. I need to get them to engage. I need to get them to trust us. I need to establish a baseline. I need to build up some communication, and I need to manage their expectations and try and work out what can they understand, what can they manage themselves, do we need additional support putting in place, are they actually doing really well and not being given the credit for it, and they're just not on the right treatment, has somebody given them inhaler that they've never actually checked the technique on and just handed it out, or an action management plan that I couldn't even understand somebody rocked up with, and this person can't read and write. So that it's more about fact finding, and yeah, it didn't go down very well. To say I was having 2 appointments where I could have had one was exactly what I kept getting. So 2 weeks later, then I bring the patient back, and we do a lot around education and developing the self-management plan with the patient, carer, parent, whoever supports them. Lots of people come on their own now, and once they've met us for the first time, because they feel quite confident to do that, and they're kind of semi-independent. There's a big group of these patients that are semi-independent, and they were often the ones who were rocking up in emergency services out of hours, especially. And we go through the usual things: inhaler technique, peak flows, anything else we need to, really, allergen avoidance. Sorry, I'll just shut the window because the seagulls are having a party. 2 seconds. We've got some nest on the roof and it's getting a bit noisy out there. Yeah, so the second consultation was more about managing the patient, making sure that they're on the right medication. Can they actually use the inhaler? Has anybody explained to them why they need to use it, what it's for, how it works? And I've got, and my team in Chest Clinic laugh at us because I've got this box of tricks, and it's a big sparkly blue box, obviously, because I'm a bit of a sparkly girl. And it's just full of random stuff. And in there, I've got fidget toys, and I've got some like sensory light things I've bought off TikTok shop. My husband thinks I'm mad. Some of the things that get delivered to my house, cheap but random things that keep people engaged. And once you've found out what they need and what adjustment they need, it's not massive. It doesn't take a lot of time. I also have a healthcare that supports that clinic, so they can then reiterate what's being said. So that I think that reinforcement and that reiteration and that giving people a bit of credit and a bit of a pat on the back, and don't presume they can't do it just because they've got a learning disability. My brother-in-law used to get really irritated when people used to presume he couldn't answer for himself, or presume he didn't know how to do something, or didn't understand something. So yeah, we need to get that baseline and really work out what people know and don't know before we then go ahead and do management planning and give them their treatment. Now, I'm hoping this is going to work. This is a little video that I did, and we did this, and this is actually on YouTube now, and this is the patient's voice about coming to an asthma clinic that has reasonable adjustments, and the reasonable adjustments we've made. So fingers crossed that it actually plays. Oh. my lovely patients who yeah, make us laugh when I said to her, just say what you like and what you don't like, and she went, I hate celery. But yeah, so what can we do? And it's not that complicated. It's really not that complicated. So appointment letters in an easy read format that the patient can actually understand. Information letters in easy read. It's, you know, the world's Googleable now, isn't it? You can find anything on the internet, and there's lots of good resources out there. Very easy to download and print off for people. Longer appointment times was a game changer for me, because I didn't feel rushed, they didn't feel under pressure, and it kind of the long game was definitely an improvement for this group of patients. So putting that time in at the beginning definitely saved that repeated attendances to ED. Making sure you can actually get wheelchairs in and out of rooms. So I hadn't even thought about this until I was doing my clinic, and I used a different clinic room, and then I realised there's only one room in our whole chest clinic that you can get a wheelchair into comfortably without having to rearrange the whole furniture. Providing quiet rooms, or I put out of hours appointments, but not really out of hours appointments. What I do is someone who's got sensory issues, I will put at the very end of the clinic, at the end of the day, when I know there's not going to be 30 other people sitting in the waiting area and banging and clattering and walk tests and trolleys getting wheeled past and all of that. It's just thinking about the person and rearranging what we do. And then looking at not brought adults. So we're very good at looking at not brought children, but not so good at looking at people who are more vulnerable, who were not brought to appointments. So I just pick the phone up and ring them, to be honest, and find out why. And I would say the majority of times that people don't come, it would be because they haven't been able to read their appointment information. So those people now have a flag on, and one of the admin team will ring them and tell them about their appointment, and on the morning ring them to remind them. And I know that's putting a little bit of extra time in, but that's a 30-second conversation. Don't forget you're coming at 10 o'clock conversation, which saves on a lot of work down the line. So yeah, so the respiratory clinic then became a sleep clinic, as I said earlier. So 40% of people with a learning disability have obstructive sleep apnea, but only 4% are diagnosed. So this was when I took over the sleep service, this was a big push for me to actually get this group of patients engaged, and to engage primary care to be aware of the fact that this could be some of the reasons, because these people don't present with the same symptoms as me or you would. So they're not typically snoring, holding their breath, got a morning headache, and got an Epworth sleepiness score of over 14. They will have behavioural changes, they'll be grumpy, and it's often put down to their disability rather than because they can't express how they're feeling the same way that we can. Because you know yourself what you feel like when you haven't had a very good night's sleep. Well, imagine that ongoing for months and months and months. It must be awful and frustrating for this group of patients. So we've adapted our pathway. We've got a one-stop clinic where I literally will see the person on the morning, explain what's going to happen, make sure they're on board, make sure they're engaged, show them the equipment and its exposure, and it's to make sure that they understand what to expect when they come to get the test done and things like that, and build up that rapport again, exactly like I was saying, and give some ownership to them, explain to them why they feel like that. We do nothing different other than offer a little bit extra time in this situation. And then we discuss CPAP, and people go, you never get people who've got a learning disability to put up with CPAP. It's horrible. The general population don't even like it. The success rate 78% for my learning disabilities clinic, and my success rate for my sleep service for the normal clinic 72. So it's the buy-in and the encouragement, and a lot of people have carers as well. But a bit more time is always spent with the people who aren't as supported, and it seems to work. And we adapt things, so you know, I've got tube covers in varying colours, and I've got specialist masks that we buy in on a patient per patient, just to ensure that they are getting the treatment that they deserve as well as everybody else, and they're not just written off. Because when I picked the service up, there was this list of patients that nobody really knew what to do with because they were very difficult to set up on CPAP. But we seem to have cracked it now, so we're getting there. So the yeah, the toolkit was developed on the back of all the work that we did. And it's really simple things that we probably all do, but probably don't think about it that much. And top, it wasn't top until I had a look at it and asked us to proofread it before it went out. And I said, we really need to put, don't assume what somebody needs, like find out from them. Don't just presume because they've got Down syndrome or whatever that they're going to need you to do everything for them. They're very independent. A lot of these patients are fiercely independent, but we just need to enable them to be able to be independent. So the number one top tip is don't presume. Use the patient passport, use the carer, use the patient, use the parents, the whoever you need to get in contact with, just to try and work out what they can and can't do and what they do and don't understand. Don't try to fix it. So you can't fix what's going on. You just need to make it work. We just need to look at what we're doing and make things work. And it's not a problem. It's just something that we need to do slightly differently. We need to think outside the box, exactly like I said at the beginning. Making sure that the patient and the carer are aware of their roles in anything that we're doing. If things can't be, if we can't adjust for them, then letting the person know that and managing expectations. We record red flags on our system at Sunderland South Tyneside for people who have been identified as having a learning disability, which is really helpful. And the passports are digital now, the patient passports, which is also great because they can be updated live, as we've seen people. Making sure that we discuss any adjustments needed in private with the patients as well. Oh, sorry, my arrows seem to have disappeared. So there we go. So the top tips, it's all about communication, really. So keep it simple, use simple strategies, make sure you ask the person what matters to them. So there was a young lady who was saying, and she was an avid Sunderland supporter, and she would not use her CPAP machine. There was absolutely no way she was using it. There's no way she was using it. She's getting a lot of stick from the carers, like we're really trying to push her to use it, and she was having none of it, and she was getting more rebellion, and her symptoms were getting worse because she was so tired and ratty. And I literally sat with her and said, why do you hate it so much? What is the matter with it? And she spelled out on her board that the machine was black and white and she couldn't have it in her bedroom. And that was the thing that was causing her a bit of trouble. So that's what mattered to her. So the carers ordered her a boot bag with Sunderland logos on, and during the day it gets zipped up in the boot bag and it's on the bedside table, and she doesn't mind having it there at all. And the deal was made that if that happened during the day, she would then wear it during the night, and we would open the bag and use it that way. And this girl absolutely loves this machine. She's, it's given her life back, really. But it's what matters to that person, and it's really important. Always checking the healthcare passport and the hospital passports, using a lot of teach back techniques. So just tell us what I've told you again. Or can you explain that to me? As if I didn't know. I use a lot of that with this group of patients. Using, like, avoiding using jargon and using shorter sentences. So not just reaming off loads of information, because retention, I mean, I can't retain information these days, never mind someone who's really struggling to understand what's going on and what you're explaining to them. It's all very new and very scary. Asking people how they prefer to communicate. So I've got one lady who likes it written down because she likes to take it away and read it at her own pace. She feels very under pressure. So I write down bullet points of what we've discussed and then she takes that away. There's a lot of other people who just like pictures, don't like the written at all, so just pictures. So there's a lot of prints off of like random pictures and things like that. Allowing a bit of extra time, as I'd already said, and additional therapy support if needed. Anything that will really support communication in this group of patients has got to be great, because we want to empower them, we want to give it back to them, and we want them to feel like they're in control of whatever respiratory disease we're treating or whatever we're doing. Even around smoking cessation, I've done smoking cessation with some patients who have additional needs and learning disabilities, and it's handing it back to them and trying to get them to understand why it's really important to do smoking cessation. So there's nothing, it's not rocket science. There's nothing out of the ordinary. It's just thinking outside of the box a little bit, and what can we do to make services accessible and acceptable and do justice to this group of patients. And this is a quote that this is my lovely John, and this is his girlfriend. And unfortunately, John passed away through an aspirate pneumonia, having been not diagnosed with epilepsy correctly or treated properly. And this was a little quote that his girlfriend always used to say: they were super cute because they were extra cute because they have extra chromosomes. Thank you ever so much for listening.
So thank you so much, Sharon. If people have questions, please do ask, but I've also wrote down quite a few while I was listening to your talk there as well. However, please other people ask questions as well. I don't want to just monopolise all the time. So I think I've been lucky enough to hear you speak before, and I just think it's inspiring what you've achieved and what you've done. In relation, so I was just thinking about sort of primary care. And in primary care, obviously things are done a little bit differently in audits and things like that. So I was just thinking primary care wise, and I just wanted to quickly drop a link in the chat, which is for CDRC. So CDRC have got free audits. So I don't know if anyone's ever tried to set up an audit, but myself as a practice nurse, I haven't failed dramatically. But CDRC have got them already set up for you, so they can find your high risk patients. The thing I was thinking, so you said obviously it's reasonable adjustments and it's not just taking into account learning disabilities. I think that's a really, really important part of this as well, because someone may have a reasonable adjustment, maybe they have to get on 2 buses to get across, or they have to rely on someone else to bring them, or whatever. I think that's a really, really important part that I came out with there. Carers and family members as well. I just wondered what your experience was with sort of carers and family members as well, Sharon, and getting them in to help, because you mentioned that in there, and I just thought that's really important.
Yeah, I mean, they know the patient better than anybody, the carers and family members, and they obviously want the best for that person, and they know what adjustments they need, and they know their likes and dislikes. So I spend a lot of time involving carers and the family members, and they know whether they're going to be kind of receptive to things that you're going to try and put into the care plan or the self-management plan, because they know the person so well, because they'll come out and say 100% absolutely not, there's no way they're going to be able to manage that, Sharon, and then you think, okay, well, we need to try something else. Because often the patients, in my experience, I think the people who are supported by carers and are supported by parents are the ones that actually do very well. It's the ones that are semi-independent that seem to struggle a bit more. And you're perfectly right what you said, Beth. It was so when I started doing this, I realised that there was a big group of patients with significant mental health problems that need reasonable adjustments, and they've kind of slotted into this clinic, although very different, not often needing the easy read information and stuff like that, but needing that extra support, that extra encouragement around their anxieties, their health anxiety, their ability to come into the hospital and into clinics on their own. As you said, there's a lot of that. So but yeah, absolutely, the carers and the parents are the best resources in my mind.
Yeah, it got me thinking about social prescribers and care coordinators. Now I know some areas unfortunately don't have them anymore, but I know quite a lot of areas within primary care do have social prescribers and care coordinators, and it kind of got me thinking about, can we utilise what we have within primary care? Because again, as myself as a practice nurse, I appreciate how limited we can be on time at times, but can we utilise our resources? Voluntary sector as well. Yeah. We've got some amazing voluntary groups out there, and I really liked what you said about knowing what they dislike. And you know, we may look at it and think, well, why do you dislike that? But actually that could be incredibly important for that person, and as a Sunderland supporter myself, I'm not gonna lie, I agree. So yeah, but I love that there's something actually addressing it and asking them why don't you like it, what is your concern?
Not just writing it off. I think that sometimes happens, doesn't it? Like the easy option, and our consultants do it here all the time. So the easy option is if somebody can't use an inhaler, we'll give them a nebulizer. But no, that's not the easy option. We need to find out why. Why can they not use it? And then work around that. Because the last thing we want is for these group of patients to be reliant on nebulizers.
Yeah.
It's just not appropriate. But it's the asking the whys, isn't it, that we're not often that good at.
Yeah. And the adult not bought code, I think, is so important. So in primary care, if you don't know that there is that code, there is now that code, that SNOMED code, or whatever we call them nowadays, for adult not bought. I believe it was Kathy Peterson who has been sort of a big champion from that up in Northumbria, and just being aware that obviously some of these patients, like with our child not bought, they might be actually relying on someone else bringing them in for that appointment. And do we have a system for finding these people who may be vulnerable and may be reliant on other people? And again, I thought your comment about wheelchairs was really, really important. So I know in my own surgery, one of the nursing rooms is really easily accessible, but 4 of them are not.
Mine's the same here, yeah.
And they'd be really difficult actually for a wheelchair to get in. Or any other sort of aids as well. If someone's got sticks or anything, they'd actually be quite difficult. Even being further away, they'd actually be quite difficult for that person to get in if they were using a mobility aid. So yeah, I think that is a really, really important part as well. And is that what's stopping them coming in? I could waffle all day. But are you happy to speak about your lived experience as well, Sharon?
Absolutely. If anybody's happy to listen, more than happy to speak about it.
I'll let you sort of take it from here. But Sharon's lived experience is quite emotive and quite thought-provoking, but I think this is quite an important part as well. Thank you, Sharon.
Yes, so from being a child, I have had asthma, and my asthma was eosinophilic. It was never triggered by allergies, and it was very well controlled, kind of disappeared in my teenage years, or more likely I ignored it. And then it came back with a bit of a vengeance after I'd had my children and settled down, but nothing more than a bit of a steroid inhaler. And if I got a cold or a flu, I would have an exacerbation, have a short course of steroids, and everything would settle back down until so a year gone November, things dramatically escalated. Well, it escalated before that, but got really bad then, and I ended up with an ICCU admission following a respiratory arrest. So what I've been asked to do is just really talk about it for a little bit, 10-15 minutes. And this is not to bash anybody in the process. It's certainly not that at all, because I wouldn't be here now. That the NHS literally saved my life on 3 occasions in that hospital admission. So that's not what it's about. This is about being thought-provoking and maybe taking something away from it that we hadn't thought about before. And it certainly did it for me as a respiratory nurse. So what I did was, I also thought I was a bit of a poet. I think it was steroid induced at the time. So I wrote a little poem, which I'm going to read to you first of all. And then I would like to tell the story of what happened and how I ended up in that situation in ITU, if that's all right. So the poem I've entitled Beer 2 Bed 3. So it started with breathing that packed up and quit, a wheeze that was so dramatic I thought, well, this is it. I said, I can't breathe, with appropriate alarm, and they shrugged and looked at me like I'd misplaced my lip balm. My lungs held a meeting, a full-blown revolt, deciding unanimously we're leaving this vault. And suddenly everything sped into blur, with strangers announcing what's happened to her. Whisked off to intensive care, it was cold and pristine, where my name was erased like it hadn't been seen. Replaced by a bed number, I was no longer me, because nothing says value like Beer 2 Bed 3. They talked over me with impressive finesse, as though I was wallpaper causing them stress. I tried to join in to gain some control, but my voice drifted off like, you're right on your own. And here's the truth, the bit no one will say. The fear isn't loud, it just gnaws away, a quiet, persistent, unwelcome refrain. What if this breath is the last in the chain? But then came the nurses, my actual heroes, who noticed my panic while others saw zeros. They steadied my thoughts with a hand and a grin and gently reminded my lungs to join in. They spoke to me kindly and they treated me whole. They patched up the pieces fear tried to control. And though I was numbered and breathless and small, their kindness insisted I mattered at all. So yes, I survived. The wheeze, the collapse, the loss of my pride, the moment my lungs tried to bail from inside, and now the whole saga gets neatly summarised. Shit, Sharon nearly died, but I'm still here, surprise. So that was me being a bit poetic after all the drug-induced incidents I had over that period. So yes, so
and I'd just say that is quite hard hitting. I think is the best way to put it. That's yeah.
Yeah, it made us think about how we label people, and it becomes very depersonalized. So January 2024 was the start of the decline of the asthma. So I got a chest infection, had a dose of prednisolone, it got better, and then it got worse again. Had another course of prednisolone, and then it got worse. Wheeze, nighttime symptoms, very, very typical. And by August 2024, I'd had 8 courses of prednisolone. I had my medication increased. So I was going to my GP and he was saying, what do we do next? And I was telling him what the next step on the asthma guidelines was, and he was just doing it. So it was Foster 100/6 on the MARC regime, adding a bit of Spiriva, adding in some Montelukast, and we were just going through the stages. Then I had an episode where I had been given 5 days of prednisolone. I knew it wasn't enough because I'd been on enough prednisolone for a good kind of 6, 7, 8 months at that point. So I felt quite well, but I just knew it wasn't right. So I took myself on a little walk over to my GP surgery, and it's not very far at all. It was a lovely day. Walked over, got to the reception area, couldn't even speak to tell the lady behind the counter my name. And she told us to sit down in the waiting area. So I sat myself down and, was really struggling, not shifting any air, knew things weren't very great. And the little old man who was sat next to us went back to the reception and said, this girl needs sorting out, like she can't actually speak. So I was taken through into the GP's room, and he went, oh, you need a nebulizer. Couldn't argue, couldn't speak to him at that point. And big learning curve for my GP surgery. So they had a nebulizer compressor, but no mask and port. Somebody ran to the pharmacy to get the salbutamol because what they had was out of date, but they had nothing to put it in to deliver it anyway. My sats were then dropping off, had an oxygen cylinder that was empty. It was a bit of a comedy of errors looking back, to be honest. Thankfully, it was escalated 999 call because things were getting pretty serious at that point. And the poor GP looked like he was actually going to pass out at this point as well, because I'd gone through a whole blue inhaler, there was spacer, I was just constantly puffing on it because there was nothing else. So I had a very interesting trip to ED, stopped on the way a couple of times to have a bit of IM hydrocortisone and whatever else they were jabbing into us at that point. Went to A&E, had some magnesium, had 24-hour admission, things settled down, upped my steroids to 60 milligrams and sent on my way again. Referred into secondary care. Officially referred into secondary care at this point. So that's when I went on the waiting list to go on an asthma biologic, and that was the end of August. And things just didn't get any better. So I was on long-term steroids, 40 milligrams of steroids for the whole time between August until we got to the beginning of November. And it just became normal for us to be like that. It just became normal for us to be breathless, to be waking up during the night a few times. Very typically things we tell our patients shouldn't become normal, but it did, because everything was in the right, seemed to be happening like it should be, but it just wasn't happening very quick. Like things weren't escalating very quickly. And then on the day after Remembrance Sunday, I can only remember how bad it was getting because my husband goes out with his army friends on Remembrance Sunday, and I went to pick him up, And I tried to phone him from outside the pub he was in, and I couldn't actually speak down the phone. And I thought, I really need to get this sorted out in the morning when I get back to work. You know, not alarm bell should have said to us, you need to go now, but they didn't. So spent the night sat on the sofa, went to work the next morning, couldn't actually walk from the front door. So got from my car to the seat outside the front door of the hospital. And then luckily one of my colleagues walked past and went, right, we need to get this sorted out. Got admitted, did the usual, up the steroids. Obviously all the side effects that go with being on steroids for so long. IV magnesium again, 48 hours. Oh, I was on top of the world. I was on 80 milligrams of prednisolone. I was virtually up on the windowsill cleaning the windows. It was great. And that afternoon, that morning the registrar came round and she said to us, I said, oh, I feel champion, I can go home. And she went, you're not going home. And I said, no, I feel fine. She said, you're not going home. Your chest's not right. So I made a bit of a deal with that because I'm a terrible patient. And I was like, if I'm all right by tea time, will you come back and let us go home? Fine. So got to about 1:30 in the afternoon. I thought, oh, can't really breathe in very well. Best have a nebulizer. There was no nebulizers. Press the buzzer. Somebody came in. Well, your SATs are all right and you don't sound wheezy. No, I can't breathe. I'm telling you, things are spiraling. This went on for a good 20 to 30 minutes. But your SATs are all right, your OBS are all right, but they weren't looking at me or listening to me. And I was telling them I was getting worse, but nobody was actually hearing that. Till eventually one of my colleagues actually wandered up to see if I needed anything and took one look at us and said, what, you don't need Diet Coke, Sharon, you need critical care outreach, like things are deteriorating. And they were still very adamant, but our SATs are all right. Yeah, well, my SATs are always all right and they don't often dip off. And someone sounded my chest and went, oh, it's very quiet. And I'm trying to say, I know that's bad. Like, that's not a good thing. There's nothing happening in there. So, yeah, the rest was a bit of a blur. So I remember a trolley coming to take us to intensive care. And I remember thinking, oh my God, I've got my pajamas on. I've worked here for 30 odd years and I'm getting wheeled through a corridor. And then the next thing I remember was waking up in intensive care and I'd had a respiratory rest coming out of the lift on the trolley, like actually just getting wheeled into the intensive care doors. Luckily, that's where I was when it happened, or unluckily, or luckily. Yeah, so they gave us a lot of drugs and they were literally about to intubate us. I remember opening my eyes and they were bagging us and the tubes were on the pillar next to us. Literally, it was that close. And they gave us a lot of ketamine because that's the last thing they do for asthmatics before they stick a tube down to see if that works. And it did work, but my goodness, it was crazy. It was like weird things were flashing around in my mind. The hallucinations of it were mad. But it was a very surreal experience because I wasn't quite sure what happened between there and there. And that was the bit that really threw us. So lots of drugs, so you can imagine, central lines, the works, everything thrown on board and things settled down. 48 hours in and then it all just spiraled again. So as soon as they started reducing treatment, things spiraled again and ended up having another respiratory arrest, but in ITU, so it was very controlled that time, if you can say that. Give us a whole another bunch of ketamine. And the consultant who was on at the time came in and she said to us, and I was saying, no, I feel fine. And the weird thing was I was forcing myself not to sleep or rest because I was really scared to go to sleep in case they didn't realise I'd stopped breathing again. And they told us afterwards you probably have more anxiety around that because you were awake and you weren't sedated and ventilated because you were listening to everything that was going on, everything that was being said. But it was being said over the top of us. People were talking about us and I was in the room, and that was really unnerving. But I had some crazy hallucinations that night after I'd had the second lot. So Ben Shepherd was in my room changing my telly over and there were squirrels running about all over and it all got a bit crazy at one point. I don't know who does that for fun, but that was not a good experience to have, taking drugs like that. And then got much better, things settled down. At that point I was on 85 milligrams of prednisolone just to keep things ticking over. Went back to the ward. And then I got the very much, well, she's a healthcare person, so she'll know what to do herself with things. So I got a lot of that when I went back to the ward, and I was put in a side ward, which was about as far away as you could possibly be from anybody else on the ward. And I think for the right reasons, they thought it was a bit of privacy, you know, she works on the respiratory ward a lot and it's probably better. But actually, as I deteriorated overnight, I had to physically try and get out of bed to go find somebody to come and help us, and then had another episode where I ended up in ICCU, and then this things seemed to just settle down, and spent another week in intensive care, a week on the ward, and then thankfully came out of hospital with lots of horrible side effects from all the steroids. It took us 3 months to wean off, and put a lot of weight on, about 3 stone I put on, because I became quite immobile. I was very breathless. I was scared to move about. Yeah, it was a very thought-provoking time. I had a lot of time on my hands because I was very scared to go to sleep. And the things that I've really took away from it were escalate early, really escalate early. Like, all of that could have been not preempted, but I think things could have been moved along a lot more quickly. Please don't call your patients by their bed number. That's definitely a secondary care thing. The on wards are very good at going, the lady in bed 3. It's absolutely horrendous. It's really is the worst feeling. And look at the person, not just the numbers. Like, really take asthma seriously. And I've been doing this job for a very long time. And the chief exec, Ken Brennan, came to visit us when I was in ITU, and all I was worried about was the fact I had my TikTok pajamas on, not the fact I was all wired up to God knows what everything else. And the only thing I can remember saying to him was, "I'm a really bad asthma nurse. It's not a good advert for your hospital. Like, I can barely keep myself alive." And he's like, "Oh, for goodness sake, Sharon, you need to not stop doing that." But it's listening to the person and taking it seriously from a primary care point of view. I felt very fobbed off in primary care, and I kept going back, going, something's not right, something's not right. I'm really wheezy on a night. But you're not wheezy now. No, but I'm awake every night, 3 and 4 times a night, having to use an inhaler. And it was the escalation. And I got a lot of conversations from the GP and the practice nurse about, well, don't we know about biologics? Because I kept saying, I think I probably need an asthma biologic, or referring in. Well, don't we know about it? And we haven't done this and this and this yet. Like, the processes take too long, I feel like. Yeah, so just, like, don't look at the numbers, like, look at the person. And also, I have to add, finally, Ben Shepherd's much hotter in my hallucinations than he is on the telly. Changing that TV over for us, the nurses thought I'd absolutely lost my marbles.
So thank you, Sharon. That, yeah, I mean, that is so hard hitting, and hearing it from yourself is so hard hitting. Yeah. I think that you said about that you kind of normalized your symptoms.
Yeah.
And that is something that we hear an awful lot of our respiratory patients do, is they normalize it. They say, well, that's just how I am, or I'm getting old, that's what I do, or I'm asthmatic, so you're right, I can't do that. And it's actually sort of looking at it and going, well, no, you should be able to do that. You shouldn't be sat there not being able to breathe. Listening to the patient, absolutely. What is normal for them, what is not normal for them. And if we take that to what you were saying before about the reasonable adjustments, listening to that carer, what is normal for them, what is not normal for them. I don't really have a huge amount to add or to put in there. I just wanted to really just sort of say that is really hard hitting, and thank you so much for sharing that. That story, that's very kind of you for sharing that story with us. And I think that question, that why is things not right? I always like the quote, I think it was Desmond Tutu said, we're very good at saving people from drowning, we're not very good at asking why they are. And I always really quite like that quote as to why is this happening. But yeah, can't thank you enough, Sharon, for speaking today. I appreciate there's only 2 of you on here, but Lola, if you just flick to the next bit, and it's just, if there is anything that you'd find beneficial next time, we're thinking next time to do an allergy asthma date in September. We're going to avoid August because obviously it's school holidays, and I'm not here much myself in August, to be fair, due to my child. So we're going to do September, and we're going to look at maybe some allergies, but if anyone's got anything they would like to add, we're more than happy to look at that as well. This will go on the Futures platform, and I think we get quite a lot of hits as well on the Futures platform on our on the webinars that we do where people haven't been able to make it. because there was more people obviously registered on this, but I think just the way that it works in primary care, people are probably a little bit stuck in clinics or again on leave. So yes, thank you so much. Yeah, thank you.
Thank you. Very welcome. Thanks a lot. Bye now.
Thank you. Bye bye.